All right, guys. How you doing? This is the TBD lecture. How you doing? It's not the to be determined lecture. It's the total body Dolor lecture. So this is not the 50-year-old Hispanic woman with ITAC, III, and pain all over thing. I'm going to try to make it slightly more interesting than that because I know you have a ketamine protocol for those patients. So I'm Pick Mukherji. I'm over at LIJ. We stole your PD. Thanks for that. It's been fun. Dude, you guys ran out of coffee, and I'm going to fall asleep in this room. Can you turn the lights back on? Would that be okay? Thank you. All right. 3 cases. First case. He's a 50-year-old guy, pain all over. EMS brings him in. His vitals, he's tachy. He's febrile. He's a little bit hypoxic. And his pain is 13 out of 10. So if you get an odd number, it's like a nurse who actually takes the respiratory rate. It's like a real number. And he's thrashing around, and he's got full body tattoos, and he's talking, but he's just sort of screaming in pain. And the girlfriend's with him. She says, I don't know. I was with him last night. We had a fun time, a little partying, some people over, but I had to go home to my house, and this morning I came and he's lying on the ground like this. It's ridiculous. I don't know what's going on. Case 1. All right, case 2. I'm sorry. We already know what case 1 is. No? All right. Case 2. 40-year-old guy who comes in to the MS. I think he took something. He ain't right. He's Brady. He's got a soft blood pressure. He's also hypoxic. We don't know what he is out of 10, but he looks kind of uncomfortable. And he's kind of moaning whenever he gets touched and kind of thrown around. He's not really verbal, although he makes sounds. And his teeth have brown goop all over them. Anybody know what this is already? No, I got more puzzle looking now. Here's the third case. 5-year-old girl with the parents. She's got meningitis. She has total body Dolor and she has meningitis. She's got a heart rate of 90 and a blood pressure of 94, and her pain is at 11, so another odd number. And they say, we went to the pediatrician because she had a fever, and he said, it's probably a virus. They give you headaches, but we worry about meningitis, so make sure she doesn't get worse. If she has weakness or numbness, or she has double vision, or she's got terrible headaches, then bring her back. And today, she can't walk. Today she's complaining of pain, and they found her crying in pain and trying to get up the stairs by crawling, and she won't stand and walk. And they say she's paralyzed. She has meningitis. So these are 3 patients that rolled in. Who would you go see first? Would you go see Tattoo Man with the terrible pain and the fever? Would you go see AMS guy with the brown teeth? Or would you say, you know what? They've lived their lives. Let me see the 5-year-old. Right? Quality life years, right? What if I told you that there was one test that they all had in common? You think the lab is broken because they keep reporting the same value for all 3 patients, and they all have it. So what is it? Our lactate? Not a bad guess. CPK! And the CPK was 12 grand. All 3 patients have rhabdo. So we're done. So we admit them all for rhabdo. Okay, thanks. Nice talking to you guys. Rhabdo. What do you guys know about rhabdo? Lots of causes of rhabdo. We basically send shotgun labs, and somebody says, hey, the CK is high, and you go, how high? I don't really care, right? If it's super high, then we start to care. I'm going to leave off infections mostly because you're going to get that in a bit, but I think trauma is where we think of rhabdo, right? That's where I first heard of rhabdo. It was crush injury and muscle damage, and all the stuff gets released, right? The CK goes up, but so does the potassium, so does the uric acid, so does the phosphorus. It's tissue death, right? They talked about gut death, lactate goes up, K goes up, phos goes up. It's that kind of stuff. So anybody know where the first biggest case series of rhabdo is from? Sort of like the seminal literature when they say, everyone knows rhabdo, it's in the textbook. What's that sort of primary source group of patients? Anybody know? London bombings, World War. Right? So there's a rubble everywhere. Just think about who the patients are. Otherwise healthy people who were home hiding from German blitzkrieg, and then they bombed them. And now if you didn't die in the bombing, we don't have ambulances to get you, right? You're not coming in septic. You're coming in trapped under rubble, but you're not dead. And then we get you to the hospital quickly enough that you didn't die already. And when we remove the rubble from your legs, we release all that crap that's been tourniqueted off. And if they sew off your leg or amputate your leg, you still get the potassium, the uric acids, all the electrolyte stuff. So the first way, if the trauma doesn't kill you, that rhabdo kills you, is the lights, right? So the first thing you do to those patients is this, is the EKG. Right? And then you save them from their hyperkalemia. And of course, it depends on where you get them, right? Because they can continue to have electrolyte variations for a good 6 hours. So doing serial EKG for a crush victim might be important. And almost like the Parkland formula, the time starts when the burn happened. The time starts when they get extracted. So people have a long transport time, are going to come up much sicker because they're going to release all that crap into their bloodstream. Now you also got to remember that there's other electrolyte and endocrine things going on. So I got a patient who's not a crush injury. He was generally weak, right? He's wasting away, weight loss, no PO intake, peg tube came out, and tea and toast guy. He doesn't eat anything, and he's coming in looking terrible. And his potassium is super low because that's what's making him weak, right? Well, low potassium can cause rhabdo, which then causes high potassium. So you get this guy, and he's got pain all over, and he can't walk, and his K is 5. And it's like, well, that's not anything, right? So again, a lot of these things, if you see things are changing, the guy's third spacing, he's getting swollen, he's got a funny EKG, you got to repeat the EKG, you got to repeat the lights. Thyroids, low or high, can predispose to rhabdo, right? It's all this muscle membrane stuff. So that's not what we usually see, though, right? Most of your patients are not going to be the crush injury people, right? Anybody get the times? This is the times yesterday. The CrossFitter epidemic. I got 2 residents who were hospitalized after CrossFit rhabdo. Anybody? Nobody? No casualties here? That's good. So why do they keep them, right? They keep them because they...
Someone who, after a Spartan race...
there you go. Yeah. How much?
Like 100.
The CK was 100? That was 100,000. That's better.
Yeah,
Yeah. So why do they keep them? They might keep them because they can't walk, right? But for the most part, everybody who says rhabdo, the next thing is they go, oh, they're going to go into renal failure, right? How do you guys do that? Like, hey, this guy's CK is X. Let's admit him. You have a cutoff for X? Does it depend on the patient? Is it automatic above a certain number? I don't actually know the answer. I'm looking for the answer. If you guys know, please tell me. I know that we worry about this, and there's only 3 things that predict renal failure. One is how old you are, because as you get older, the kidneys die. Right? So when you're older, the creatinine tends to be higher, no matter what you got. Dehydration's a big one. So there is a difference between the well-hydrated, over-exertional sports guy and the trapped in the rubble away from all food, or the nursing home person, right? So dehydration's a big thing. And then acidosis. So if you are old, dry, and your bicarb is low, you're at a high risk for renal failure. A lot of our CrossFitters aren't that, right? They're young and well-hydrated, but they hurt a lot. So it's sort of, if they can walk, but they're peeing brown, and they can drink, giving them a liter or 2 in the ED is okay, but saying, oh, well, their CK is 12,000 and it needs to be less than 5 to go home is kind of nuts, right? And if you admit them, they're admitted for 3 days. So there are probably younger, healthier people who have a little bit of rhabdo, who can go home. What about the values? The lab value that's normal in your lab, I don't know what it is, but it's got a big red H on it when it goes above something. 100, 200. These are normal values. These are asymptomatic patients in offices who have nothing, right? This is 1.5 times the gender and race-related lab value. Now, when you hear anybody say gender and race-related lab value, you got to take it with a grain of salt. The lab value that was the average of the people in that study from New England, where there's like 5 black guys and like 80-year-old white men. It depends on the populace. But I think the idea is that normal CK values probably run and can run in asymptomatic patients much higher than what our lab likes, right? So if you got people who have a CK of 500, and the plan that you get from your sign out is give them a liter of fluid and repeat it, wait till they sign out, and then go pull their IV out and send them home, because they can drink, and they're young and non-acidotic and non-dry. All right, how do you stop kidney injury? You give them fluid. That's it. Now, what have you guys been told about how do you stop kidney injury? Lots of fluids, not just a liter, like 2. So fluid matters, but fluid matters as you might expect, especially in the people who are dry, because you know. But if you want to get a little more nuanced about this stuff, what do people say? Well, it's the myoglobins in the tubules. It's the acidosis of the urine. There's other stuff that maybe matters. So over the years, we've asked about like what kind of fluid, LR or NS. The answer, the lit-based answer, is it doesn't matter. But if it doesn't matter, and the price is pretty similar, and we're not in a fluid shortage, which is maybes, then the tilt is maybe LR is a little better. Maybe, right? So if you don't care, and they have a crush injury and they go into surgery, surgery loves LR. Give them LR, right? So no one cares. If you started saline, no, it's okay. And if someone cares, okay, maybe LR is a little bit better. What about meds? Can you give them mannitol? Can you give them bicarb? So don't give them mannitol. It doesn't work. And it's probably more of a dangerous drug than we give it credit for. If you want to give them bicarb, you could if they're, you know, acidotic and you're admitting them and you're worried about their kidney. And then how would you do that? Nurse, give him some bicarb. Bicarb drip. So how do you write the bicarb drip?
I mean, immediately you're sending that patient to ICU because they're on the drip, so I wouldn't do that.
A bicarb drip's got to the ICU? Wow. I like LIJ better when I visit other places. So if the bicarb drips get into the unit and they're not that sick, then I guess you're giving them a push of bicarb, which is kind of a generally not useful thing to do, right? People make H's more than there's bicarb in the hospital. The point of the bicarb drip might be to give them a sodium load, some fluid, and make the urine alkaline so the myoglobins don't get all frozen. But we don't know if it really works. But that's one of the, maybe it works. But if you do it, you put 3 amps of bicarb in D5 water. Don't give them hypertonic saline, right? Don't make a couple amps of bicarb in NS, because now the sodium load has gone to 300, and that's you're repleting hydration, right? You give them isotonic fluid. So don't put bicarb into saline if you're going to make a drip, right? And if you're going to do it, it's all about the myoglobin in the urine. It's not about the CK. CK goes up, but the urine is clear. You're doing a great job. All right, meds. So this is kind of easy. You just Google meds, and everybody knows statins cause rhabdo. But frankly, it's not that common. Statins cause muscle pain, myopathy, much more often than they cause rhabdomyolysis. So I can't take a statin because it hurts, not my CK went to 20,000, right? And yeah, it's a long list. We kind of know the list. Let's go back to guy 1, the hurts all over guy. What's going on with this guy? He had a party, you know, some people came over, food and drink, good time. He was up late. He was cleaning up when I left. I went home, and I came in, and I found him on the ground, and he's yelling. So why is he in rhabdo?
Molly or cocaine?
Okay, so we're thinking maybe he partied. All right, great. What is the most oh man, all right. What's damn it! Damn you, new version PowerPoint animation. Cocaine, LSD. Funny synthetic drugs. They all disrupt your muscle membrane. They all can give you rhabdo. But the most common drug that gives you rhabdo is alcohol. And the book says something about the membrane disruption of alcohol. But the reality is, if you pass out on the ground, you're at risk for rhabdo, right? You guys know the old gomes who do this with no meds on board, and they have rhabdo. But why? Because you've done surgical ICU. So I know you have slept for 13 hours in a row and not woken up in rhabdo and peed brown. So why did this guy, you know, who had a nice evening, I don't know what he did, but he certainly had some alcohol, maybe did some other stuff. And then they found him on the ground. He's yelling and screaming. And febrile. What the hell happened to him? How did he get rhabdo? He was healthy like 10 hours ago. When you sleep for 14 hours, you roll, right? You know that business about getting people off the longboard because they got a stage 1 in like 2 hours? Guess what? He's had like a stage 9 because he's been down for 10 hours. But his brain is gone, so he doesn't roll. So any cause of altered brain and down will give you rhabdo. I don't care if it's Valium or heroin or alcohol. It's just that alcohol is kind of common. And alcoholics fall and stumble and hit themselves, right? So there's lots of reasons that alcohol is the #1 player. Why is he febrile?
Good aspirin.
Beautiful. Right middle lobe pneumonia. He was on the ground snorting his own juices and unconscious for a long time. He aspirated. He's got aspiration pneumonia. Done. And then he actually can't walk at all. His CK keeps going up. They start imaging his back, going, what the hell's going on with him? He's got a bleed. And his left psoas muscle swells up the 3 times the size of the other psoas muscle. And so they're putting egg crates on the other side of him. It's a mess. Because he drank. Terrible. How about my second case? It's a 40-year-old. EMS brings him in. I don't know. He was in the park. He was down. So this is a little across the bridge knowledge I'm bringing you guys from LIJ. You know, I was one of the last residents, maybe me and Jessica Wang might have been the last residents who did the crossover. LIJ resident came to Jacobi and vice versa. But basically, we are near Creedmoor, which is a psych facility, and Creedmoor is near a couple of bodegas, and the bodegas are where like 80% of the synthetic marijuana K2 comes from in our area. So we got guys who just leave the ER, go to the bodega, EMS picks them back up, and like they just, within hours, they're back. It's amazing. What that stuff does when you, if you look at it, it looks like, you know, brown crap. It looks like weed, right? But it's a dark brown, mushy, coffee grindy weed. So when you smoke it and you pass out, it just sits on your teeth and it becomes this brown, crusty goop. When you say, hey, this guy's unconscious, and you go, well, listen, I wonder if he had a head bleed, and then you look in his mouth and he's got the goop, you're like, oh, he's from the bodega, right? So our tox guys do want to say that, listen, any of these synthetic things can cause rhabdo, whether it's because of the passing out business or it's because of a direct toxic, who knows. But they don't want you to call it K2. They hate that the triage nurse writes, brought by EMS K2 ingestion. Because we don't know what the hell that means. Half of them are punching the wall and they're looking like LSD patients. Half of them are unconscious, they look like heroin overdoses, right? And they get intubated. So they don't want you to write that. They just want you to go by the symptom they're having, right? It's a sympathomimetic kind of problem, it's a sedative kind of problem, and you deal with it. There's no antidote, so you're just doing supportive stuff. Both the agitated and the comatose will get rhabdo. And what happens to this guy, by day 3, he's oozing from everywhere we stuck him. And after the electrolyte shifts and the fluids, and then the kidney beans go, the next thing for the sick people is they die of DIC. Which is terribly bad, but especially so if you have muscle damage when you get DIC. It's a high mortality. It's very rare. What about my third case? My little girl. So they gave her like some ibuprofen, they put a line in her, they gave her a little fluid, she's got a CK that's up, and she's slightly more comfortable, but she won't walk. Like in the bed, she rolls on her stomach and knees around to get to the edge of the bed to talk to mom. So what she got? She has a viral myositis, because that's what kids get after they were just sick with a fever and something. Particularly flu will give you that in kids. But kids with rhabdo, it's going to be almost all infectious. It's either the really bad things or the viral things, right? It's not always benign, and some of these kids have an underlying congenital problem, a weird muscular dystrophy that's a delayed thing. Calf pain is super common. So I like that because it lets me remember it. Oh yeah, Duchenne's kids, they get those giant pseudo-hypertrophy calves, right? That's a Duchenne's muscular dystrophy thing. So a kid who's got a CK and calf pain has myositis, and it's probably post-viral, and she may have some underlying genetic thing, and maybe they should look at that, because I don't want her to die when she's 20, right? So post-viral in kids, rhabdo in kids, think ID or soft tissue infection. It's either viral or bacterial, and it's autoimmune in adults. Influenza is the most common virus that does it in kids. Anybody know the most common bacterial process that's not a necrotizing process that causes rhabdo? Good, because it's a stupid thing, but I don't know, boards are stupid things. Legionella is the most common bacteria that causes rhabdo. So there you go. You got to remember the causes. So if there's a take-home here, it's just get a CK. The level of pain doesn't correspond to the level of CK elevation, right? The level of pain doesn't correspond to the level of injury. And depending on when you see them, where in the spectrum of they just put the boulder off my leg, or I'm on day 2 of my virus, or it's been a week and I'm getting worse, the lights and the numbers and the creatinines are all different, right? So these are sort of shotgun things. People have pain, get a CK. Don't get an MB, just get a CK. So how they look like in the beginning may not predict. Many patients with elevations can go home, right? If there were a number, I'm not saying there is, but renal failure seems to be more likely when you get above a CK of 30,000. So if you said, I don't want to put everyone on a bicarb drip, that's crazy talk. If you said, hey, this guy looks pretty good, you might think, well, when the CK is greater than 30,000, they are at increased risk. So a guy with a CK of 40 or 50, who's also older and a little bit of the low bicarb and dry, maybe we should put him on the bicarb drip and call the MICU, because maybe we'll prevent the dialysis, right? Urine output is the best indicator of fluid. 203 cc. That's it. Questions, comments, please.